Hello, good morning everyone. My name is Frederico and I'm the CEO of Amparo. And what we are doing at Amparo is redefining mobility for lower limb prosthetic users. I want you to start by imagining you just been through the trauma of losing a lower limb. And like that wasn't enough, you still have to go through a long and very tough process to just get a prosthetic device and start your rehabilitation. And the reason for that is that the process nowadays is a trial and error process with multiple visits to the clinic, with a lot of different steps, a lot of error, and where you have to go and have multiple hours of fabrication. So very complex, very long, a lot of workshop work, and trial and error pretty much.
¿Cómo están?
So one of the big problems here is this is a process and a problem that affects 6.5 million lower limb amputees just in Europe and North America, and this number is expected to double by 2050. And it's costing a lot of money and achieving very poor results. Our process, on the other hand, is something you can do anywhere. In under an hour, you can have a patient walking fitted with a direct fit socket that you can still remold and adjust as needed very fast. So you're speeding up the rehabilitation process, making the process a lot more comfortable for the patient and a lot better, as well as allowing for a lot of other possibilities. So when you compare the conventional process with ours, what you can see is instead of 4 to 7 visits, you have just one. It's not a trial and error process, it's directly fitted to the patient. You deliver the prosthetic in the same day, in 1 to 2 hours, and you can remold the socket up to fully remold it up to 5 times. So you can react to the volume variations that are normal, especially in new amputees. In terms of Amparo, we are driving the next revolution in prosthetic care with a single appointment, direct fit, remoldable socket that can be fitted anywhere and is supported by real-world data with our real-world data solutions. We have currently almost 5,000 patients fitted with our sockets. We are in about 40 countries, and we are expanding fast. Also, very important from our project is that our technology allows us to reach very difficult areas and allows prosthetic care to be provided in conflict zones. For example, we are a member of the Restoring Hope initiative in Gaza, where we have been fitting. We are the only technology allowing prosthetic care for amputees in the region. Just for the recent conflict, it is estimated that there are 15 to 20,000 amputees, 70% of which are women and children, and we are helping to get them back walking, which is very important. Part of our data solution, just for you to have an idea, is a solution that allows to monitor activity and automatically classify the functional level of a prosthetic user, understanding the needs they have in terms of components. And this is being used as well in Gaza and is allowing us to understand the impact of the initiative, where we've seen people being fitted with a prosthetic and in the same day they start walking again. They do 13 kilometers or more because they need to get food and they need to get water. And that's it. Thank you very much for your attention.
Hi, thank you for the presentation. Roel Dekkers from Next Gen Ventures. So 2 quick questions. Who performs the fitting compared to standard of care? And can you tell me a bit about the durability of your products?
Yes, so the fitting is still performed by the CPOs, the certified prosthetists. So the same people that do it nowadays, the only difference is with our method, they can do it a lot faster and they can do it anywhere. So they don't need to see the patients in the clinic, they can actually visit the patients at their homes, in the hospital, during the rehabilitation or anywhere else. And they don't have to spend a lot of time on the manufacturing process, but they can spend that time in the rehabilitation process that is a lot more important. The durability is the same as the current standard, so we have no less durability or problems compared to the current standard.
Andy Gaze, Health Tech Capital. I'm over here.
Yes, sorry.
What's your go-to market? This is a difficult market to reach.
So we've been on the market since 2021. We've been doubling our sales on a yearly basis. We are about to reach 1 million in sales for 2024. So it is a difficult market in the sense that you have to go through the clinics, but once you start having the traction and working with local distributors that have the network, you start getting people more involved and you start gaining that traction. The main challenge is always getting people trained on the technology and giving for people to give enough time to see how the technology works and the benefits it brings.
In the long run, do you aim to still sell directly, or are you thinking on partnering with auto boxes or large manufacturers?
So at the moment, what we are doing is selling directly in some markets, using distributors in others, and that's the plan we are seeing. We don't know. Maybe in the future, partnering with big clinics will be a solution, but it's something that is difficult until you have a certain dimension. So.
Hi, Sergio González from EIT Health. Can you explain further about your team?
Yes, so our team currently is 11 people. We have our chairman that is the very experienced in the industry. He has founded the company that is the first bionic hand in the world that was sold to Assur. We have Wesley, the CTO, that is a mechanical engineer that developed the technology, that invented it. I'm the CEO and I'm a biomedical engineer. We have Diogo, our chief marketing officer, a lot of experience in communication, marketing and design. Then we have our sales manager, that is the only person selling and is achieving 1 million in sales, so very good salesperson. And we have our clinical specialist, a trained prosthetist that is doing all the training and helping us with development. And then we have some people on development, operations, and manufacturing as well.
Okay, Federico, thank you very much.
Thank you. Thank you.
Next up, Bartłomiej Pishivarovsky, Partnership Director, Clininode. I got that right?
Yes, that's correct. Okay, good morning, everyone. My name is Bartłomiej Pishivarovsky. I'm the Partnership Director at Clininode, a digital health company that is aiming to solve the problem of clinical data quality. Right now, is it working? Right now, the healthcare world, the clinical trials world, is going through rapid transformation, and data plays a crucial role in this transformation. The market itself is worth about 42 billion euros. There is a significant problem, though, that we have identified. The way that data is collected right now in the form of clinical node is unstructured, incomplete, of low quality, and difficult to use. The same issue was recognized by Professor Iwona Ługowska, one of the youngest women professors of oncology in Poland, and Professor Jan Poleszczuk, 2 PhD in mathematics and data science. Together, they've been working in a clinic on several scientific projects, and they have developed a new method of collecting data. They have built a team, and then with the support of experienced businessmen Rafał and Robert, Clininode was found. The main assumption was that the data was not collected, not used retrospectively, but we have focused on creating a tool that would help medical professionals to collect data prospectively. The result is complete, structured, high-quality data that can be used for different applications. For example, it can be used for clinical research, for clinical trials data automation, patient recruitment, and also training new AI models. Fun fact, only about 10% of AI models is now being trained on real patient data. The rest is, yeah, it's difficult to say. Our technology was recognized by Novartis and IQVIA. IQVIA is also our distributor. We are present in different countries across Europe. We're participating in different consortiums. Our go-to-market strategy has pivoted from going to hospitals. Now we are focused mainly on directly on pharma companies that later provide our solution like ECRFs and other tools to the hospitals, clinical trial units they are working with. Right now, in order to continue our mission, we're looking for 2 million euro funding. We would like to reach 100K monthly revenue, and we would like to test other territories like USA and India. We're also active in European Health Data Space Initiative, supported by by European Commission. Okay. I think I managed to make it in 3 minutes. That's it. Yes.
Thank you so much for the presentation. What's your value proposition for hospitals?
For hospitals, well, first of all, if the hospital is conducting any research activities, we can provide them with high-quality data, and we can automate different processes within their systems. And our solution is user-friendly, so doctors like to use our solution instead of HIS note-takers or formulas, templates, etc.
And are you also monetizing through them?
Yes, however, this process takes much more time, so we have pivoted to pharma companies more these days.
I was just going there. How's the business model or the revenue model with the pharmas, and how long does it take to close each one of them?
It takes less time, because in case of hospitals, it might take half a year, up to a year, sometimes because of tenders, etc. With private hospitals, it's a bit faster. With pharma, it's probably also, it takes a few months to close deals.
Yeah, and the GIS Health Tech Capital. I don't understand. Are you on top of Epic and Cerner and the existing medical records, or is this something to just extract data and then there's a lot of competition using natural language processing?
No, we are working as an add-on on web browser solutions, so we are not interfering with current processes. That's why doctors like this solution, because they don't have to learn anything new or get any certification to use our product. And any more questions? Yeah, one more.
I'm sorry, but there's no time left. That's it. If you want to ask a question and you don't get a chance to because of the timing, you can feel free in the trade show to approach the presenters.
Yes.
Okay, thank you very much.
Thank you so much. Thanks.
Next up, Vijay Reddy, founder and CEO of Doctors Pharmacy. Welcome.
Thank you, sir. Good morning, everyone. My name is Vijay Reddy. The biggest problem of today is, compliance and adherence. Everybody knows the patient is not taking the medication, but nobody knows when they miss the dose. Last year alone, US spent over $723 billion on just prescriptions. Yet, for the last 20 years, the number of deaths from cardiac disease or from diabetes are going only up. US spent over $10 trillion in prescriptions alone, and each year we fill 4 billion prescriptions a year in US alone. Why? Because we spent billions of dollars in training doctors, tens of billions in building the infrastructure for the hospitals, and hundreds of billions of prescriptions. But we are focusing on the wrong. The biggest problem lies with the patient. 80% of the patients don't even ask for refill on time. And 63% of the patients, they just simply forget to take the medication. When they don't take medication exactly as prescribed, they end up in hospital, costing the US system hundreds of billions of dollars more each year. So what are we doing? Doctors Pharmacy, we compliance pack all the medications. All 6 o'clock medications goes together in a pack. And then, while our robot is packing them, we take the image of the pouch on both sides, and we text the image to the patient 5 minutes before they have to take. If they don't respond, we send the repeated reminders. And once they say yes, they took it, that is the complaints, the whole thing is we capture on the patient's doctor, patient's pharmacist, and patient family can see on the app that the patient is taking the medication. In addition to that, we also take the blood pressure, blood sugar, temperature, pulse oximetry, and weighing machine. So for the first time in the world, we are the only company that can tell the patient blood pressure is high. Not only high, it is high because the patient is missed the dose a few hours before. And we also developed the technology called PillPal. It goes on a pin like this, and it goes on a patient's clothes, and 5 minutes before, it announces in a voice, in their grandchildren's voice or their children's voice, saying that you have to take the dose. When they press this button, we capture the compliance. And it's the first PPP platform where physician, patient family are connected together and everybody knows what the patient is doing. If the patient is not taking the medication, they can intervene to make sure the patient takes, which increases their life. The B2B model is we wanted to sell the model to the insurance companies and the health hospitals. And the B2C model is we want to sell the pill-pile technology to the patients. And we have a team. I'm the founder, and Dr. Michael Turner is Stanford and Harvard educated, worked at Mayo Clinic, and Raj. And we have 70% of the money so far I raised, $4 million, came from the doctors all over the US. And we are asking for $10 million for 24 months leeway, and we want to expand this all over the world.
Thank you very much, Vijay. Now it's time to move on to questions, less than 2 minutes.
There's a lot of companies doing this, including PillPack from Amazon. So why are you better? And do you have any data showing improved compliance?
PillPack only stops at making the compliance packs. We go a step further, and we also do the RPM together.
But do you have any data showing increase of compliance?
Yes, we already...
How much?
82% in compliance alone.
What was the patient data sets and what type of medication?
All kinds of, on average patient we focused on is over 65 because that's where the biggest problem lies. And compared to their previous pharmacy refill pickups, because there is no true compliance data till today from anybody in anywhere country. So we are the first company to be able to provide the true compliance data.
Yes, two quick questions. Where is your market? And if you are planning in Europe, for example, if you know the competences that they are here.
We are right now in US, we are a 3-year-old company, and we just applied for the patents and the trademarks, and we are planning to launch in India by next summer, and we wanted to come to Europe probably in 2025, and we are looking for partners.
Hi, Daniel Monarchlup from Altano Capital. So how's this reimbursed? Who's paying for this?
I only have 3 minutes, so I couldn't cover everything. In US, when the patient do not take the medication, when we call them, they pay us. For every text, if we can get like 20 minutes of conversation with every patient, each text can be counted towards few seconds. Under ICD code, we can get $54 for every 20 minutes. And if we have another 20 minutes of conversation, if I make a phone call and talk to them, we get another $38. And the UK, I don't know.
Okay, thank you very much, Vijay Reddy. The time is up. Appreciate it. Thank you.
Thank you, sir.
And next up, Ludwig Fendt, co-founder and CEO of Elixion Medical.
Thank you so much. Yeah, hello everybody. So my name is Ludwig. I'm co-founder and CEO of Elixion Medical, and we fight the care shortage in hospitals with our IoT and AI platform. So whenever somebody of you goes to the hospital, you of course want the best patient care possible for yourself or your loved ones. And the biggest input factor for that is the people working there, so especially medical doctors and nurses. Reality is that there are just not enough of them, and the ones who are there look like on the picture here. And the problem gets even bigger over the next year due to demographic change. At the same time, the nurses spend up to 1/3 of the time for manual monitoring and documenting the patient data at the bedside. And that's exactly what we want to change. So we want to free the nurses from the manual monitoring task by automating it with our own IoT devices and use the proprietary data to analyze it in real time and predict healing and complication of the patient at the bedside. Our first product on this journey is the smart catheter. It consists out of an IoT device you see here, which can be attached to any kind of fluid bag in the hospitals, and it automatically measures the fluid over time in the bags. So for example, urinary catheters or surgical drains. It sends then the data to our software where it can be analyzed, where the medical doctors and nurses can get notifications if the patient gets into critical situation, etc. And where, of course, over an API, also the documentation in the electronic health record is done automatically. And the impact for that is huge. So on the one hand side, the nurses benefit from getting rid of a relatively stupid routine task, and for a hospital that sums up to 200,000 hours of time saving per year. And the other hand side, we get way better data for the doctors, and the patient benefit with that for better care quality. So our plan is to go to market in Q2 2025 after our MDR certification. We will first go to the ICUs, into the hospitals, and sell them our product for 5 euros per day and device in a renting model, so hardware and software combined. And we do this on the one hand side with our own sales, which we're already building up, and scaling it faster with sales partnerships, what we're already working on. So far we have 20 hospitals in our pilot pipeline, want to do it before market entry or before certification. And we have one of the biggest German distributors signed an LOI with us. So the market for that is huge. We have a 4 billion market only for this first product, so for the whole monitoring of fluid lines. And our goal is to get 300 ICUs as a customer in the next 2 to 3 years, which would give us a revenue of 10 million euros ARR per year.
Okay, Ludwig, thank you very much for the presentation. Your 3 minutes are up. Let's move on to the question section.
What's your sensitivity and how do you prevent false alarms?
Yeah, so the measuring itself, we have plus minus 5% roughly. Yeah, so we are way more accurate than the current method, because right now the nurses go there and basically watch it, right? So it's a completely manual process, which of course really subjective, but also incorrect. And there are studies that let's say that 100% of the results basically are wrong right now. So we are way better than this.
Does it actually change the workflows? Or is it still time consuming? Because I understood that the nurse has to go to your software, I guess, validate the information that has extracted, and the API is sending it to the electronic health records.
No, so we try basically to integrate in the existing workflow as best as possible. So that's why we have the APIs in the PDMS and hospital information systems basically. So they can watch their standard results there, but if they want to get, let's say, into deeper analysis, they can go into the software, so especially for complication detection. But for the normal workflow, for the standard workflow, it doesn't change.
In which EHRs, or how do you actually integrate with the EHRs?
So we have, you mean, so from the interface itself, so we have a HL7 and FHIR interface basically, which can be adapted to any kind of PDMS or hospital information system.
So is the alarm in the nursing station there? Is that the way it works?
It's both, so it's on the device itself, so based on the norm, and we have also the possibility to get the notifications then on the PDMS or also on your mobile phone or whatsoever, so this can be changed.
So I was under the impression that in the US there are competing products. Why are you better?
Not so really. So they're the competitors basically from Israel mainly. So they produce, let's say, a high-cost niche market products, I would say. So for ICU, so let's say the product costs 2,000 to 4,000 euros, and their one-time device $50 to $200. And we are really focusing on the mass market, which is 90% cheaper than this.
Okay, Ludwig, thank you very much. The time is up.
Thanks.
Round of applause, please. Thank you very much. Luva Marcus, Evira.
Thank you. Hi. I'm Luva, CEO and co-founder of Evira. And we are on a mission to end childhood obesity once and for all. 3 years ago, a boy with severe obesity named Oscar came to a healthcare center using Evira. He was 12 at the time, and he was unable to take the stairs in school due to knee pain, and was ashamed to have to take the elevator by himself. Oscar was often unable to participate in the games played by the other children, and experienced social exclusion. His parents had tried everything. But this time was different. This time they came to center using Evira. The healthcare professionals helped Oscar's family identify changes that works for them and to realize those changes. Oscar's family received a special body scale that doesn't show any measured weights when you use it. Instead, they can view his relative progress in the app, enabling them to understand the impact of everyday choices and activities on Oscar's weight. Evira enables the healthcare professionals to track this change, and we help them reach out when necessary to support. We'll get back to Oscar in a moment. We started sales in 2022, and Evira is now used at 44 centers across 5 countries. We charge the commercial centers per active patient, and I'm proud to announce that we have just reached 1 million ARR. We're growing because Evira works very well. Healthcare professionals using Evira can provide better results at a lower cost per patient. We are now looking at expanding internationally and at combining Evira's outstanding long-term results with the short-term outcomes of weight loss medication, taking us to the 150 billion market for weight loss services. Here's the team that produced these amazing results. But I bet you're curious what my connection is. And the answer is the third co-founder, Professor Claude Marcus, my dad. He is a pediatrician who has worked in the field since before I was born, and Evira builds on his extensive experience and research. I'm also here today with Andreas, our CTO, and a friend I've known since kindergarten. Oscar, he has now lost a significant amount of weight. He can take the stairs in school and participate in most games with his friends. This weight loss has extended his expected lifespan around 10 years and will enable him to perform better in school and in future work. We're now looking at expanding, so if you know any relevant investors, anyone working in the field or interested in the subject, it would be amazing if you could connect us so that we can help more children like Oscar. Thank you.
Sorry, I missed part of the treatment. Like, what is the treatment that you're actually providing? Like, is it that you're connecting with pediatricians, or is it a digital therapeutic that it can help? Because there is a lack of pediatricians out there, so I don't know, what does the value lay?
So that's exactly what we do. We build a connection between the family and healthcare providers. Sometimes pediatricians, usually dietitians or other related fields, so that they can build a better relationship and provide a better support to the families.
So the application is just for monitoring purposes.
Exactly.
It's not doing any treatment itself.
Exactly. So mainly monitoring. We're giving advice primarily to the healthcare center. So we give recommendations to the healthcare center. What is a healthy weight progress the next few months based on the family's goals and motivation and situations?
So I'm still a bit confused. So you're just tracking the weight scale? I mean, is that what you're doing? And do you have any data to show that people change behavior? Do you have no cognitive behavioral therapy? There's no intervention?
The intervention is on a more human level. So traditionally, if we look at weight loss, the hard part is not to know what to eat or what to do. The hard part is to actually change habits in everyday life. And the way to achieve that change is to work long-term in the family. And traditionally, what is successful is to provide very, very frequent contact. So in the US, they recommend 26 hours per year for treatment to be successful, which is unfeasible for families. It's one session every 2 weeks and very expensive for healthcare. We can provide sort of the same level of support with a fraction of the time from the healthcare providers by recommending the healthcare providers who they should reach out to when, and by giving easy to understand feedback to the families on how they're progressing.
Thank you very much.
Thank you.
Next up, Anchon Caballero, Heuristic CEO.
Yeah, so we started with heuristic 5 years ago when a nurse made a wrong identification error of my grandfather. Basically, they thought that my grandfather was another guy and provided him with the incorrect drug. Like my grandfather, in Europe, over 500 million patients suffer from identification errors every year, with a market cost of over 200 billion euros. In the US, identification errors are much higher, around 600 million identification errors with a market cost of over $1 trillion. But why are these identification errors happening? These identification errors are happening because of the current patient identification solutions. For example, healthcare cards are the #1 fraud solution in healthcare because patients swap them. And then in the case of the bracelets, they have printing issues, they wear off, then the health staff can provide the wrong bracelet to the patient. And there are some patients, especially in psychiatry, that they refuse to use these bracelets. So what's the solution? Heuristic. So heuristic is a software solution to identify a patient combining fingerprints and artificial intelligence. But we are not just identifying the patient, we are also helping with the management and with the tracking of the patient. Basically, this is how it works. The patient will go to the hospital, they will scan the fingerprints, then the fingerprints will get linked to the medical record, so every time that the patient puts the fingerprint in the lector, they are gonna be correctly identified. The magic of our technology is in the artificial intelligence because basically we are the first company in the world that has developed a neural network able to identify fingerprints in adverse situations. As I mentioned, we are not just identifying patients, we also help with the management by providing real-time data. For example, how many patients are coming per day, per month, per year to a healthcare entity? How much time does it take to make every process, or where the patient is located in real time with the tracking? And combining everything, we are able to avoid bottlenecks. We are GDPR and HIPAA compliant. We are not Facebook, so we are not going to sell your data. We are just, we never have access to it. So our business model is a B2B SaaS. We charge per identification to healthcare entities. We can sell directly to hospitals, to insurance companies, to software integrators. For example, Entity Data, which is the largest healthcare software integrator in the world, is our main investor, and to pharma for medical trials. We have 4 signed contracts in Spain, Portugal, and Italy, and we have 15 LOIs in 7 different countries in Europe, Israel, and the US. This year, we applied to an EIC accelerator combining 9 hospitals, and we have over 20 prospective customers all over the world. Our team is fantastic. If you want, then you can ask questions about this. We've been part of the largest healthcare acceleration programs all over the world. So we've been in MIT, we've been with NVIDIA, we've been with Oxford University, we've raised over 1.3 million mostly in grants and awards. Our target market is going to hit the 81 billion valuation by 2028, and we are raising 1.4 million euros, and we already have 800K committed. So in 5 years, we see ourselves as the gold standard to identify patients. And my last message is, you have 2 chances. You can invest on us or help us reduce these identification errors, or the second one is run the risk of being part of those statistics. So thanks a lot, and you can follow us on LinkedIn or just send me an email. Happy to answer it.
Quickly to the questions. 1 minute, 45 seconds remaining.
Just one question. Do you actually then substitute the current process that hospital has, or are they doing it in parallel? Like, how does it work?
Yeah, so if you tell a hospital that you are going to substitute a bracelet, you are out since the first day. So we are combining it. So for example, for inpatients, right, we are combining it with the bracelets. And for outpatients, they are not using any bracelet, they are just using the healthcare card. So we have a freedom to operate there, and we don't need to fight with another solution.
Do you have to sterilize or disinfect between patients? How does that work?
Yeah, that's a really good question. Actually, we are using one device from the US that works with ultraviolet lights and eliminates the 99% of the viruses. So this means that the device, when you put the fingerprint, it will destroy all the viruses such as COVID, so the next person is not going to infest.
Yeah, but if you use UVC, you have to be careful. It could hurt people's eyes.
No, it's just for the fingerprint. It's in the lector, so the lector to take the
It's
picture.
integrated into
Yeah,
your
yeah,
device.
exactly. So the lector actually uses the UV lights to clean the fingerprints.
You had pharma in your customers. I assumed it's in the scope of clinical trials. Can you explain maybe a bit more?
Yeah, so actually, right now we are just working with hospitals, with funerary companies, because there are a lot of identification errors there, and with software integrators. But we are starting to talk with pharmas, such as Novartis, to implement the technology during the whole medical trial. We are not selling yet, but it's an area where we can sell the technology there.
Thank you very much, Ancho.
Yeah.
That's okay. Thank you. Very good presentation. Luisa Dobre, okay, CEO and founder, Comed Health.
Thank you so much. Hello, everyone. My name is Luisa Dobre. I'm the CEO and founder of Comed Health, a company based in Zurich, Switzerland. So what we are doing, we are transforming the way doctors and nurses communicate through a real-time collaboration platform that pulls data and uses AI to actually save lives. So let's take 2 steps back. Did you know that the third cause of death is medical error after heart disease and cancer? And did you know that 80% of that is because of inefficient communication? Well, the reason for that is the healthcare systems in a hospital, they're very fragmented, employees are mobile, and there are a lot of misdiagnostic, very hard to find out what you need and who you need. So what we do, we solve this problem by enabling communication and collaboration between clinical staff through a real-time, patient-centric communication platform that is proven to reduce up to 2.5 hours for a doctor per shift, and 1.5 hours, for a nurse, and 1.5 hours for a doctor. As well, reducing hospitalization time by more than 1 day. So how does it work? We pull data from whatever different system, being EHR, nurse call, lab, radiology, whatever device needed, and we are pushing it to any stakeholder in a hospital in real time at the right point in time. So we are enabling systems and stakeholder in real time. What's our business model? We are a typical SaaS platform, modular, so the more use cases, the more money we charge, up to 22 million ARR when we are dealing with more than 100,000 users. Also in Q1, we are now embedding AI, so probably many of you know this use case, ambient voice recognition, coding it and pushing back into the EMR. So we have this patient-centric communication platform where we pull in real time the relevant physicians and nurses, and we are enabling them to also pull the data in real time in the EMR. In terms of competitors, we have a bunch of relevant competitors in US. Some of you maybe know Tiger Connect, and a lot of secure chats out there, but what we do is much more than a chat. We are actually fully integrated into the workflows. Where are we today? We are deployed in 26 hospitals in Switzerland and Germany, and we are about to start in Emirates and Italy, where we have letters of intent. And by in 12 to 18 months, we should be break even and reach the 1 million ARR based on what we have in the pipeline, just 20% of what we have in the really late pipeline, letters of intent and final negotiations. So in order to achieve that, we are raising part of a growth plan, the first tranche of 600,000, in order to reach profitability, number one, expand to GCC with our first confirmed project, and embed AI and roll it out as an upsell module to all our customers and beyond. So thank you so much. I am just...
3 minutes of presentation. Let's go on to the questions, 2 minutes.
I'm sorry, I'm confused exactly what you do. Vocera is a voice-based system there with a panel. What exactly do you do to replace Vocera?
We are not replacing Vocera. We are focusing on the European market. and GCC.
So is it a better communication between nurses and clinical
Doctors,
staff?
yes. So I would say Vocera is a competitor, but Vocera already was acquired for $3
Is it
billion.
based on a cell phone? I mean, how do they get messages to each other?
So it works on any type of mobile device, and it works on any type of desktop, of course. We embedded in the EMR as an iframe, but also it works on mobile. So
Did
physicians.
you create like the team staff for that patient there, and then so that they can find who is on stars, and then do you have an automatic nursing scheduling system update about who's in charge and when they change, what's the hospitalist and everything else?
Exactly. So in the moment the patient comes to the hospital, we create a chat room around this patient. We pull you as the treating physician, the nurses, and we always change the nurses and the doctor based on the scheduling system. And as well, we push
and what's
data.
your pricing system?
So it starts with three Swiss francs or €3 per user per month, and then can grow up to fully integration.
But if there's a team of 20 people on these patients, there's like 20 times $3?
I mean, we generally charge hospitals, right? So we are having SaaS B2B for the entire employees of the hospital.
Oh, per employees.
Yes, yes.
So it's millions of dollars per year.
For one hospital with 1,000 users, it's about 100,000, just to give you, starting with 100,000, depending on whatever modules. And we are also now changing the business model because we add new modules starting with Q1. So this will increase.
I think that that's all the time we're going to have now for this section of questions. So Luisa Dobre, thank you very much.
Thank you so much.
Stephen Felix, CEO, Medial Health.
Hi, I'm Stephen Felix, founder and CEO of Medial Health, on a mission to revolutionize healthcare in the Caribbean and Latin America. This comes out of personal experience. I'm from St. Lucia, and my medical records were lost, right? Can you imagine that over 90% of medical records in the Caribbean and Latin America are still on paper? That's over 600 million records. That leads to medical errors, delays in care, higher cost, and also a lack of reliable data. Our solution is a cloud-based, low-touch EHR system where we help physicians convert from paper to pixels in less than 24 hours. How do we do it? Minimal infrastructure. All you need is internet and a web browser. It's a decentralized solution where we create a network of patient data, and we basically give physicians and medical facilities access to that data. It's an interoperable system, and it's AI-powered with ambient listening for charting and schedule optimization. How it works. It's shared patient records, right? So in every country, one system, all of the records are shared between the various physicians and practices, and, well, with patient consent, of course. That data actually follows the patient wherever they go, so their care continues. We use secure messaging for task management and AI automations, etc., just for more efficiencies in those systems. It's a $2.6 billion market with very few competitors. There's a lot of money going now from NGOs, development banks for digitization efforts. And in the English-speaking Caribbean, there's over 8,000 physicians. This is our initial market that we're going to target in the next 18 months. We charge the institutions $170 per seat, per physician seat, right? And we have tiers with various features, etc. Our early traction, we're in 2 countries, 40 physicians that we invited onto the platform. We've generated revenue by converting them from trial to paid, and we've basically collected over 100 feedback items. That means they're actually using the system and they're contributing to make it better. Our go-to-market strategy, we're going to use local AEs and our customer success team to do demos and onboarding, and all of our basically users are going to come from independent medical practices, hospitals and clinics, and also partnerships and research. Our projected revenue, with only 800 physicians, we're projected to generate 1.6 million a year. This is our next target. This is our team, lots of diverse experiences. We can talk about that later. But we're raising $1.5 million for profitability to strengthen our product offering and to enter new markets through localization of the software. Join us as we revolutionize healthcare in the Caribbean, Latin America, and other emerging markets. Thank you.
Any questions? Here we go.
What is the number one reason for not adopting any of the multiple existing systems, and why are you addressing it?
So, good question. One of the number one reasons for existing systems is you basically have to pay lots of money upfront for customizations and implementations, right? Why is that? A lot of them are US-based, so a lot of things, even like the date format, when it comes to software, that's different, right? So many things are different, and for us, we basically studied the various workflows in the region and how healthcare actually works before actually going to build the system, right? And this is one of the reasons. So basically the barrier to entry is like pretty low for them to get onto the system. Training is very minimal because we've made it very user-friendly. And basically, a physician can find almost everything they need, that's in outpatient for now, on one single screen. So no longer having to navigate from screen to screen, basically to enter a diagnosis, etc.
30 seconds, time for one quick question.
Hi, thinking about the scalability into LATAM, does your solution work also in Spanish or only in English?
So not yet in Spanish. That's one of the reasons we're raising money to do the localization. Not just that we would translate it, but we also need to test it and make sure that medically everything is correct in the system.
Stephen Felix, thank you very much.
Thank you.
Thank you, Stephen. And finally, Vili Costamo, co-founder and CEO of Medicube X.
All right, so hello everyone. I'm Vili Costamo, the CEO of Medicube X and a medical doctor. So let me start with a few questions. So what is the #1 leading cause of death worldwide? It's cardiovascular disease. How much of it could be prevented? 90%. Do we have the human resources to pull that off? Obviously not. So now, preventive healthcare usually chronically fails. Simultaneously, we're running out of the young people to take care of the increasingly numerous elderly people with chronic conditions piling up. Now, we are having two approaches here. So we automate routine work in healthcare, and simultaneously we automate the risk assessments of cardiovascular events, strokes, heart attacks, type 2 diabetes, and also enable screening in a new way. So what we have developed here is our eHealth station, a fully autonomous device that makes it possible for an untrained person to measure all of their vital signs and the non-invasive risk factors of cardiovascular disease in 5 or 6 minutes. And to top it off, it's automatically disinfected with UVC light in between users. It's a patent-pending system, and it ensures that it is 100% safe. And all of the results gathered here can be automatically transferred to any patient information system. Now, we are a subscription-based business. So healthcare providers, clinics, hospitals, depending on the country, public healthcare, health insurance, pay us 28 to 50,000 euros per year per unit, depending on contract duration. It's basically a plug-and-play solution. So we have thousands upon thousands of happy patients, hundreds of happy staff, and now in Finland we are already at the stage where we are exponentially scaling up. Now, in the last 7 months, we went from having paying customers in 1 country, Finland, to now having paying customers in 5 countries, including Germany and the UK. And now in Finland, we have already reached a level of having national level partnerships. So starting from February, anywhere in the country, our users can transfer their information to their GP fully digitally, no paper involved. And now, everything you've seen so far, we have already built, we have already shipped, it's already used. And now what we are doing now is that we have developed AI-based algorithms for identifying and quantifying cardiovascular risks and risk of developing diabetes. without blood samples, 100% self-service. It's a first ever thing, no publications, no pre-existing patents. And we can make more accurate estimations of the 10-year risks of a person than the current gold standard methods that require blood. And we are currently writing the patent applications for these.
Okay, Billy,
yep.
Thank you.
All right.
We're going to move on to the questions. 2 more minutes.
So is this supposed to be in the physician's office while the patient is waiting, doing their vital signs? Is that what the promise is?
That's one part of it. And so currently we have this in clinics, in hospitals, but these could also be placed, let's say, in workplaces or in some other public location.
So there's been some massive failure in this space. People raising $500–600 million all failed. Why are you going to, what's different about yours?
Yes. So this is specifically built for the pre-existing healthcare system. So we don't serve patients.
So not in supermarket or pharmacies, it's going to be part of a physician's workflow?
Yes, pretty much, yes. So B2B subscriptions, we don't serve patients. Yeah.
How do you assure the disinfection between all the patients?
Yeah, as I mentioned, like on the inside, we have in multiple different locations, we have these UV light sources, and it has 2 different layers of presence detection, so it knows when it has been used and when it's no longer in use, so it can do it automatically.
And how many times you have to wait until you use it again after one patient?
We're talking, just 2 minutes. Yes, no, well, the mic is being passed, so you have any? Yeah.
So how does that get paid, or how does that get reimbursed?
Yeah, so it depends on the country, and it depends on the system. So it's always the healthcare provider that pays us. So it could be a hospital with the budget from the state, or then they could be reimbursed for patients seen. Yeah, but we have fixed annual prices.
Okay, Vili, thank you very much.